Good afternoon to everybody. We can start the session that is sponsored by APT Medical and EuroCTO Medical. We will have a really interesting presentation on new devices that we can have in our cath lab for managing some complex cases, and I think that will be really interactive. So we can start with the first lecture by Dr. Yang from China that will present a CTO case from China.
Good day, ladies and gentlemen. I'm Junqing Yang from Guangzhou, China. So glad to attend this symposium. During the next 15 minutes, I'm going to share you a case. This is the case I did early this month. With the case, I'm going to address how important it is for a CTO case to pick up entry point correctly and how to pick up it correctly. This is an elderly gentleman with heart failure-like symptom, poor control risk factors. Echoes show the abnormal segmental motion, but the LV ejection fraction is still preserved. The diagnose was standard in the outside hospital, and the mid-AD totally cooled just around the take of the diagnose. There is a shadow of calcium over here. Yes, the calcium always adds up the CTO score. But for me, the shadow of the calcium always show me the cause of the total cooled vessel. So, to be honest, in some cases, I love the calcium. Or maybe I should say I love the shadow of the calcium over here. And another thing is we cannot see any perfusion to the downstream vessel. Maybe a little some, very poor out of our vision. This is another view, the left shoulder view, shows a similar thing. And also this right shoulder view, similar information. In the spider view, we can also see quite clear the shadow of the calcification over here, but nothing else. Nothing for the caudal view. Now we check the right coronary artery. We hope to find some collateral perfusion, but the situation is quite disappointing. Another view showed the quite predominant right coronary artery and the PTA perfused the septal, but there is still no visible collateral channel. And also we pull up and exclude if there is some independent epicardial collateral channel, like take-up beyond the ostium of the right coronary artery to perfuse the distal LVT, but there is nothing. So, what can I do for this case? I think the strategy left for me is only a good anti-grade attempt. We also consider if the CTA help. Yes, CTA may add up some evidence of the viable myocardium, but in terms of the distal vessel, we don't think the CTA can help a lot. Even they show some image of the distal vessel, it helps a little in our procedure. But for IVUS, yes, I do want to say we need IVUS. We need IVUS to identify the true entry point, very precisely enter the entry point. That's what we do. Every day, the volcano IVUS is only available. So first, we pull back from the diagonal. Can we see anything like a occluded LAD? Distally, there is some stand. Proximally, there is a small side branch this way. The side branch go up. And proximally, a bigger side branch at the opposite side. That must be the so-called septal, but nothing looks like a occluded LAD. So we turn to the septal. We pull back distally around here, just below the ostium of the diagonal. We can see something. No matter the size or the position or the shape, here it must be the occluded LAD. And a little bit pull back, this must be the good point to entry. I mean, to attack with the wire. So this is the good news. And this is my habit. I regularly do a integrated tip injection to find out if there is some clue. Sometimes with high pressure injection, we can find there is some residual channel, residual stem of the occluded vessel, but no, not for this case. By the way, we use a 1.9 French, quite slim microcatheter, just to compatible with the volcano sense in the 7 French guiding catheter and in the not so big vessel as well. First, I use a field XTA followed by a guide first, but I can never catch the vessel wall, always slip down. Then I switch to a Conqueror Prof. This time, yeah, I catch the vessel wall and cut in some tissue. So we carefully move on, advance the IVUS sensor to check if it getting the correct entry point. But see here, this is the wire. Obviously, it's too low. The wire just go down below the entry point of the occluded LAD. So this is not correct. We must pull back, pull it up, and try again. But this time, it's still not good. The wire's over here, and the LAD is around here. It's still too low. Okay. Then I switch to another wire. There's a Conqueror Pro 12, and then also make a different shape. There's a shallow primary curve and a longer second segment to make it entry higher, to make it enter higher. At this time, when we enter and move down the IVUS, we can see anything in the entry point. When we pull back IVUS, we can see the wire appear just in the outer side of the occluded LAD. that means it's too high. The entry point is too high. Okay. We check angiogram to understand the geography. Okay. Then pull back. Try again. But this time, the level is good. The wire show at this level, but just the orientation bias. Yeah, we have to pull back and counterclock, turn a little bit the tip of the wire. Try to enter the true APT occlusion. That's what we did. We lock the patient very precisely, carefully, maneuvered. Okay. After the Conqueror 12 get in, we check again the angiogram. It looks fine. Also, the eye was show. See, this is the good position. The wire is just in the center of the occluded APT. At least proximally it is over there. But when we look at the angiogram, according to the shadow of the classification, the tip of the Conqueror is a little bit point to the outer side. We better pull back, control the tip, and turn it down over here, over this way. We turn out the IVOS catheter, advance the microcatheter, make sure the tip of the microcatheter get in the CTO, and make sure everything is stabilized. Then switch the wire to the XTA. With the XTA, we pull back carefully, try to redilate, make the tip pointing down, but the first trial failed. You can see that the course of the wire is not good. Then we try again, pull back, use a diffract technique. That means carefully twist, make the tip pointing down, then little bit push, and this time when I tenderly twist and push the wire, everything looks beautiful. Follow with the microcatheter. There is still some resistance, but I twist and drive. We use a tip injection not to identify the true lumen, but to find out the size of the distal vessel and the distribution of the side branches. Then pre-dilate with a small balloon and IVOS. This is a true long view. Everything is in the intraplaque crossing, and there is some myocardial bridge distally, proximally. There is some plaque over here. Most important, everything is in the intraplaque. Then pre-dilate with a bigger balloon. The 2-5 stand deliver at low pressure to protect the distal tiny vessel. Then provide and postdilate. Postdilate with a non-compressed 3O balloon. This is the angiogram. Finally, this is another view of the vessel. To summarize, I would like to say it's hardly to over-evaluate the importance of to pick up the CTO entry point correctly. In some cases, especially for those we don't have other chance, it deserves a lot of time, a lot of patience, and considerable manipulation to find out and enter correctly and keep your wife in the intra-prac course. That's it. Thank you very much.
Thank you, Dr. Yang. Now we can go on with the second presentation by Dr. Mattesini from Firenze. That he will tell us about a new device, a new tip spheric balloon for post-dilatation. So please, Alessio.
Good evening. Thank you, Roberto. Thank you to EuroCTO for the opportunity to test and to share our initial experience with this device, with the balloon and the extension catheter. This is a case we did a few days ago. How can I manage to advance the slides? Okay, can I start? Okay, this is a 75 years old male with hypertension and obesity, and in February he had a typical chest pain and was admitted to another institution for inferolateral ST elevation myocardial infarction. This was the situation. The right coronary artery was not seen in many attempts. So the operators, according to the ST elevation, decided that the culprit was this circ that we can see here in the spider view. And trying to dilate and then to put a stent in this very, very tortuous circ, he had a stent dislodgement, and so he was obliged to put a stent with a ping-pong technique in the left main just to stabilize the dislodged stent. And this was the positioning of the stent in the left main. As you can see here, there is the undeployed stent, which is from the left main through the circ. And this is the results after stenting the left main. After the stenting, they did many other attempts to check the right coronary artery, but without any cannulation. And since there was also a retrograde filling from the left system, they decided that it was closed, a chronic total occlusion. During the hospital stay, the patients had experienced also a ventricular fibrillation, which was promptly interrupted with cardioversion, and he was stabilized and discharged with ejection fraction 35. He was referred to our institution 3 months later, more or less. This was the situation on the left coronary artery system. As you can see, there is an eccentric stenosis on the left main. There is this circulation for the right coronary artery. This was a right radial, an EBU catheter 7 French from the right radial. And what to do now? We decided to fix to study the situation with OCT after ballooning the circ toward both the marginal branch and the circ. And as you can see, there was a smooth lesion with this undeployed stent which was lying in front of the carina from the left main toward the circ and the marginal branch. In order, the marginal branch is more or less the same size of the circ, so we decided to put a stent toward and to perform a decay crash in order to fix this bifurcation. And usually we do perform double kissing crash, but in this case we decided to skip the first kissing because of the multiple layers of stent facing the bifurcation, and so because we were worried about reaccessing this marginal branch. This is the result of the stenting of the marginal branch with the not fully expanded stent, which is now jailed towards the circ. And then we proceeded with the stenting the circ with a Xian Sierra 3 by 23 millimeters. This is the inflation. We put it at the ostium of the circ. And here we were very, very happy to test this new balloon, which is characterized by this spherical tip, which is made in order to avoid entrapment in cell struts when re-entering, for example, side branch like this one, which is compromised by the presence of multiple layers of stents. And we can say that, at least in this case, it was able to cross effectively the stents, the multiple layers, and to perform this final kissing. It was inflated until 30 millimeter at 18 atmosphere and with quite good results. The concept of this new balloon is that thanks to this spherical tip, the force when pushing it into a stent are reflected, and you have so more chance to enter the cells and to enter inside the stents. Also, in particular, in complex and tortuous lesion, when a non-compliant balloon can get entrapped, with this spherical tip, you have a very, very easable delivery of the balloon. And in this Reconquista Spanish registry, in this very complex setting of lesion, with a large use of extension catheter, you can see that after failure of a NC balloon, you had a very high grade of success with the new spherical tip balloon. We then ended the procedure of stenting the ostial left main with a 4.5 everolimus eluting stent. And this was the final results at the angiogram, which was also confirmed with a final OCT run. So we were planning to perform to complete the revascularization from these collaterals, but trying to cannulate the right ostium. As you can see, this was not a real total occlusion. There was at least some flow antegrade. We were able to advance, you will see, a wire, but the point is that any catheter was able to correctly direct toward the ostium, and so was jumping out the coronary. We were able in the end to have a good cannulation with, after advancement of the wire until the mid-segment of the right coronary artery, and then with a microcatheter which was advanced until the ostium of the RCA, and this system was used in order to advance this very smooth guide extension, which is named Expressman, and with this system we had the right backup in order to advance the microcatheter until the second segment of the right coronary artery, and then exchange with a very stiff wire, which like this Grand Slam, which was then used to perform the angioplasty. The lesion was very calcific. Was so used small balloon in order to advance a 3.0 non-compliant balloon, and then to predilate with a shockwave 3.0 balloon. After this very complex preparation of the lesion, we put a stent 4/12 with this final quite good results. And thank you very much.
So Alessio, we can say that probably the culprit lesion was not the circ.
We finally realized that the culprit lesion was not the circ, but this right. But you know, during the day it's easy to cannulate. The patient arrived in the middle of the night in this hospital. Yeah, they did many attempts, and we spent a lot of time in order to cannulate this right coronary artery as well.
Yeah, I remember a case during the Turin CTO summit. We decided to perform an ostial CTO PCI because it was a planning case. But once we were in the lab for CTO during the live, the right was open. So it was also the problem of missing culprit lesion.
But
that sometimes
it was very complex to cannulate this right coronary artery. We tried many catheters. Only this amplas left was able to at least see the coronary, but not to work because of the alignment.
Yeah. So thank you very much. Then we can discuss about this new balloon. So we have the last presentation. It's a pleasure to have Carlo Tumscitz from Ferrara Hospital here to show us something about new microcatheter and guide extension from APT Medical. So thank you very much, Carlo.
Thank you from the panel. I'm so happy to be here. I will talk about these new devices. I'm pretty sure that everybody, when he faces new devices, want to know if there's something new, something getting a step ahead, or is just another thing that he will never use. So I'm trying to explain you if these catheters worth a try. We know that in CTO, the most time-consuming part of the procedure is the wire crossing. So normally we take a lot of attention of the wires, different wires, technology, etc. But if you remember what happened in CTO field, we know that we need microcatheters. We need for guide wire control, for tip injection, for coils delivery if you have complications. And that after 2010, the development of a new microcatheter who was able to dilate also the channels. It was called like channel dilatator. It was able to change the field because I think much more, a vast amount of operators started to perform a retrograde procedure. The question now is if we need one microcatheter or one microcatheter is not enough, because we know that we have a lot of features that we ask from a microcatheter. We need a microcatheter who has a good torqueability, good flexibility, pushability. Obviously, durability, small profile, good tip injection, but we know after an amount of experience that there is no microcatheter which have all these features all together. So I think the idea is that in one laboratory we need more than one microcatheter, of course. Which are the situations where a microcatheter probably needs the best performances? When there is tortuous collaterals, small collaterals, tight angles, and obviously if you are working with epicardial vessels, we also want the microcatheter to be not too aggressive, because if you see from the video, if you're pushing too much in a epicardial vessel, you can create a big damage, and that's a big problem. These are the characteristics of different microcatheters. Obviously, they're not all, but as you can see, there is something new in the market. So I'm talking about the APT microcatheters. These are just the specs that we see from the chart, so it's not easy to understand the behavior of this microcatheter just from the specs. But what we see now is that there is something new coming in the field, I think. These are the two bigger family of these microcatheters. The first one is coiled microcatheters, 2.6 French of outer diameter, so basically not far away from what we know. It's the most famous and the first channel dilatator that came in the market. And then there is another one that's actually two different kind, but they are very similar, that have different outer diameter from 1.7 to 1.9. They are braided microcatheters. Obviously, the tip is stiffer and it's not tapered as the 2.6 French. I think we actually can recognize there is a similarity to other microcatheters in the market. What's the difference? I think there are other differences related to the shaft length, because these microcatheters are available from 110 to 170 millimeters. So actually, my question would be, why to use a different length? I think there are cases where, for example, we know that we have to path a very long, we have to do a long path, for example, for distal epicardial collaterals or septals, where I think the 170 could be something that could be easier to use for that reason. Obviously, there are some additional tricks to use it, because it's difficult to pull out, so sometimes you have to use an extender guide wire to pull it out, but I think it's something that could be useful in difficult cases. And for example, in patient where we need the strongest force to push, 110 could be another option for antegrade approach. And then another thing that you can choose this catheter with 1 or 2, 3 markers in the longest length of these catheters. So I want to show you one case. This is total occlusion. We can see some collaterals flow from the right, from depth septals to the left system. There is no, not big septal, but something coming to LAD. As you can see, there is a bifurcation. The LAD is not well visible, but it seems that there is some doubt about the course of the vessel after the diagonal. So we tried actually to go first retrograde because of this ambiguity of the proximal cap. And it was very easy to go down with a guide wire, and also the APT microcatheter followed it very well up to distal. But as we know, we don't want to go distal, we want to go proximal, and that was the problem, because we took something like 25 minutes, tried to redirect the guide wire in proximal, but after 25 minutes injection and everything that came in mind, we skipped. And we tried to solve the problem in another way, because the guide wire was always going down because of the angle of emergency of the septal. So we were going antegrade, and there was a little tapering. So the guide wire, I think it was a Gaia 3, I think it went down up to the diagonal. And after going to the diagonal, we were able to see that probably the occlusion was proximal, but the LAD came from a diseased part, but open part of the vessel. So if we see from here, we see the LAD, it's coming 90 degrees down from the occluded vessel, but there is some flow. So probably we were able to pass through. And that was another image that was false, because we took another something like 20 minutes, 1 hour to try to go down. No way, no guide wire could be able to go. So we were assessing a little bit better the microchannel, and so we found there is a septal to septal going directly to LAD, and I think that was the only other choice that we found at that place. So with the SUO 03, we were able to, the microcatheter here was a conventional Corsair Pro. We were able to go down with a SUO 3, and as you can see, we were finally reaching the other guide wire in the diagonal. After that, I won't show you, but the Corsair was not able to cross this tight angle, so we shifted for an APT catheter, and as you can see here, the images are not pretty good, but the microcatheter was able to cross this angle very easily. The problem here was to go also in this case toward the proximal part, because the guide wire was going down to the diagonal, not in LAD. So we decided to trap the guide wire here in the diagonal, and then to have a little bit more force, and then we don't need it exactly a reverse cart, but after several dilatation to help, we were able to cross retrograde up to the proximal LAD. As you can see, the guide wire went in the circumflex here. Then we pre-dilated, so the story was to create a space and then to go antegrade, and we used the same microcatheters, just pulled back a little bit to redirect the guide wire to LAD, as you can see here. And then after that, we were able to stent the LAD with a good result. There is some disease in the distal part, but as you can see, there is much more to do here, so we decided to plan another angio at 1 month to see what's going on with the distal LAD and if we have to complete the procedure. Then I would like also to talk about the guiding extension from APT. That's another option that we'll have in the market right now. Obviously, I don't have to say more, but in the past, this kind of procedures would seem impossible. I think with the guiding extension, everything seems really easier, and we can do very good. We can do this with very good results and not much effort. My technique that I will share with you is that I use the guiding extension in these cases using a balloon, so an anchoring balloon in the distal part, and then I pull the balloon, the shaft balloon, I'm pulling while I'm pushing the shaft of the guiding extension just to arrive very distally. Other use of the guiding extension is the selective injection. It's coming very often that we need special catheters to cannulate the coronary after TAVI, and this is very useful with guiding extension or in, for example, anatomical anomalies. This is a case, for example, where we use the guiding extension to retrieve a trapped bore of a rotablator. As you can see here, after cutting the rotablator bore, we were able to go down, and then after a strong traction, we were able to go back. Can you see that it's pulling and then it came back? And these are other very interesting techniques. Roberto knows it very well. It's a clever way to use it when we have to do rota with the bifurcation or where there are stents, and it's very, very useful. So I think everybody should know this. And also there are the technique related to CTO, so we use guiding extension to increase micro support. Sometimes it's useful to go down in septals when there is not much support from the guiding cut, or the guide wire assisted reverse cart, the single guiding catheter externalization. This requires 8 French guiding catheter and a 5 French or 5.5 guiding extension, so you have to know exactly the size of the catheters. Or we can create an handmade snare. I won't show you, but it's very clever. Sometimes it's useful when you don't have the size of the snare. You can use it to create an handmade snare. And which are the differences from different guiding extension? There is a range of diameters, because obviously not any guiding extension goes to 7, for example. There are some guiding extension which goes to 8, and just one brand has the 5 and 5.5 French extension, as far as I know. The shaft length is different, so this length in some brands it's just 20. There are other brands who has 20 and 40. In APT, they decided to go to 35. I think it's clever because it's longer enough to go very distally. There are one special, sorry, can I go back? That I don't have, mi puoi mandare indietro una diapositiva? Or maybe like this, no. Okay, that's great. Great. There is just one brand who has a balloon inside of the guiding extension that it is useful trapping. And there is this new, this novelty, the presence of side holes. What does it mean, have a side holes in a guiding extension? This is actually the situation that we face sometimes. It's not always like that, but if you're treating a long vessel and you can see that the pressure are really damping a lot, so we have to be very quick, or we can use these holes that could help a little bit more. This is another case. This is another occlusion, so collateral flow from the right to a ramus branch. This is a patient really symptomatic for angina. We discussed a lot this indication because the other vessels are pretty normal, so he was suffering a lot of angina, so we decided to treat it, even if it was a little bit tricky. We were pretty sure to go antegrade, but the antegrade wire went completely out after several attempts because of the tortuosity, so we decided to shift retrograde from this epicardial posterolateral to ramus branch. This is the live navigation. I think it was a Sion wire, not even necessary to use a suo. And as you can see, we are very close to the distal target. And then back to the ramus. Then the procedure went a little bit difficult because from retrograde, there was this movement that's very common when you use an epicardial vessel. So the wide wire was not controllable enough. So what's happened actually is that the guide wire went up to the left main in this section. So we definitely decided to go for a rendezvous with the guiding extension directly in the vessel, in the proximal part of the vessel. To advance the guiding extension, we needed to go in a branch, so we decided to, let's say, sacrifice a branch of this vessel. We anchored and we go down, and so we were able to go back in the guiding extension, even if the movement, as you can see, it's very alive, so it was difficult to get back to the guiding extension, but the vessel, after 2 or 3 attempts, we were able to do it. Okay, so as you can see. Then we decided to stent, and this is the final results. I would like to end with another case, if I have 5 minutes more, which probably have all this feature all together. This is an LAD occlusion in a very complex patient, low ejection fraction, and anatomy with dominant left circumflex, diseased left main. There is a disease in the distal left main. So we decided to implant intra-aortic balloon pump in advance. We don't have impeller right now. That would be really useful. And as you can see, the LAD has this occlusion with some ambiguity here. There is a septal, but it's not really clear which is the path of the vessel. So we decided to go, obviously, from retrograde to be sure of the path. But unfortunately, as you can see, the navigation was this. And this is the APT catheter going up. It's very smooth. As you can see from this image, there is a very good lubricity of the surface of this catheter. So even if it's not strong, has a very good pushability. So you can go, you can see here, I can go up to the cap. Okay, then we decided to go on, and we were able to cross with a retrograde crossing, and the guide wire went to the circumflex, so I'm pretty sure it was good. But what was the problem? The problem here was that there is a tight angle in the proximal LAD, so it was very, very difficult to go in the left main. So we decided to place a guiding extension here, but as you can see, the vessel is very big, so they were lying on different planes. So it was very difficult to go inside of the guiding extension. Maybe here an 8 French would be easier to use, but we didn't have at the moment. So we decided to go up for a ping pong technique to go in another catheter, but we were not able to go in the other catheter. And despite several attempts, we decided to you know, when the guide wire goes somewhere else, you follow the guide wire. It went in the same catheter, so we have the second guiding catheter, but we were not able to go here. We went to the same, so we accepted as a sign of the destiny to go just for one catheter. It's a 7 French, so it was still able to perform the retrograde from 7 in the same. So we decided to predilate over the RG3, externalized from here, from the same catheter. So we have just one catheter working, but there was some calcium here, huge calcification, and the balloon was indented like this. So we decided to place another microcatheter to go down with a rota wire down in LAD. So you can see the 2 microcatheters facing one to another. It's like a rendezvous. And then to go down with a rota wire and performing a rota in the mid-LAD, as you can see. Finally, the rota crossing, but it was not easy. Very.
Carlo, we need to close because.
Yes, okay. The end of this procedure, I'm sorry you cannot see what's going on here. There was also perforation, but this was the good results, the good end result. Okay, I'm just saying that the guiding extension are essential. We need probably several and different microcatheters, and the guiding extension are the best friend of any interventional cardiologist, in my view, and we welcome all companies that creates new models and customization of well-known products. Thank you very much.
Thank you. So we have only 5 minutes for the discussion. We can have Dr. Yang connected with us. Or we can start with you. So, Alessio, we have so we have a question for the website about your spheric balloon. And they're asking if it's useful also for pre-dilatation with non-compliant, like a normal non-compliant balloon, or useful only for instant post-dilatation?
In my opinion, the main topic for this balloon is post-dilatation, when you have to re-enter a stent with also sometimes also with minimal malapposition, you get stuck with non-compliant balloon, and this one is crossing. Same thing when you have to recross a side branch, but not so far great experience, but perhaps in some very tortuous and calcific vessel, this shape of the balloon can really help to go through the vessel.
So I think that can be, we need to try to, because the profile is good and these features are really interesting. This spheric tip can reduce the friction in the calcified lesion.
Also in calcified lesion, I can imagine that when you have some speckles, you get stuck with normal balloons, and with this one, perhaps you're able to track the vessel.
Yeah, also because in your case you have many struts inside this.
We were very happy to see that this balloon fly through this bifurcation with 3 struts and also the non-deployed stent.
And you can perform kissing balloon with 2 spheric balloons?
Yeah, you can do it, at least in a 7 French we did it with no problems. To be honest, I'm not familiar with the size. I don't know if, for example, with 3.5, if you can go in a 6 French.
Okay, thank you very much. So, there are some other questions from the audience. We can go with I have a question for Carlo. So, your experience with this new microcatheter, I'm really interested about your opinion because APT Medical has different microcatheter. Someone is coiled and other are braided, so depends on the profile and the structure of the microcatheter. So, which is, in your opinion, one good microcatheter that we can add in our cath lab for and why we can? What is your suggestion about that?
I think the construction is very useful. So for some reasons, I feel the coiled one very close to the most famous catheter, so it works pretty the same. So they're just torquing and advancing, twisting the microcatheters. But I think the braided one, I think they have something more. They are more lubricious than the other catheters. So I think in very difficult, for example, epicardial, they should be kept in the cath lab as an alternative.
Because the profile is less than Caravelle, or not?
Yeah, they're quite similar, I think.
Quite similar with good lubricity.
But the difference is that they're like rubber, but so they don't feel very strong. But when you push, after a while it goes. So I think it's because of the lubricity and the construction.
And the tip is like Caravelle, or is tapered or not?
It's quite close to the Caravelle, so it depends because there are 2 braided kind. One is smaller, so a little bit thinner, and probably closer to the Caravelle, and the other it's a little bit bigger and maybe more close to the fine cross, as you could imagine as a comparison.
Okay. So I think that we need to close the session. So thank you very much to Alessio, Carlo, Dr. Yang from China, and APT Medical, and EuroCTO for the invitation, for the symposium. We have seen new material that we will be happy to use in the future, that that can help us in having the best approach for our patient to this complexity. Thank you very much.